Good afternoon. We have in our midst Dr. Mon Matthew, Director Critical Care, Lakeshore Hospital, Kochi. We welcome you to the Natco Pharma Specialty Criticon 2024 studio. And we look forward to your advice for the young generation of doctors in the space of critical care. And these are associated with antibacterial resistance. So my very first question to you is, how do you foresee the changes in the critical care management?
Looking back on the years that has gone by, I see that it is difficult uh, for patients and the human race to exist. We come to this world on a temporary visa, but the microbes are going to be here for millions of years. Trying to fight them is not the answer. We must learn to live with them. And at the same time, the focus should be on how we can carry them along with us without decreasing the immunity of our natural resistance which God has given to us. The younger generation is reading a lot of books. They are trying to personify on their educational basis on what to catch up with in the most difficult of times, especially when you have MDR organisms, pan-resistant organisms, and very little to choose amongst drugs, because companies feel that spending millions is not the answer to overcoming a generation of a decade or two. This is happening also in antifungals. And there are more products in antifungals than in antibacterials. At one time, gram-negative sepsis was much more than gram-positive. Now we find that there is an equal balance between the two. And the biggest problem that I see going through literature from different parts of the world is how to overcome antifungal resistance. So we are going into an era where our past knowledge is not going to be supported. We have to have the current knowledge, and also this is the decade for prediction rather than foresee something and then try to treat it. You must be able to prevent rather than cure. So I wish the younger generation could focus more and not be based on artificial intelligence or Google support for their future. And they're not going to get much from the past. Because if you look in 1940s, late 40s, we had penicillin coming into the market. And penicillin was a hallmark which lasted for many, many generations. In those days, intravenous injections were not very common. And we started off with intramusculars, then we went on to oral antibacterials. And then finally we came to a stage where we found out that all the discoveries made by multinational companies and Modi ji's Make in India project not withstand the ability to fight these organisms. So genomics or gene-centered process of PCR, instead of going into what we call microbiological surveillance, is more important as we look at the future.
Thank you so much for that insight. And you also brought about antifungal, apart from antibacterial. How do you want to advise the young ICU generation of doctors? What is it that they should do to enhance patient care?
The most important thing is to realize that they by themselves cannot be the masters of all I see. See, every guy gets a degree. Every guy gets a post-graduation. But the ancient Hippocratic faith and the clinical science by the bedside which we have been taught are the hallmarks of a good doctor who is going to better himself in the future. Going into a lot of technology really answers a few things, but it does not give you the practice and the confidence to go ahead, because that is acquired by years of knowledge. And if the young think they can override the seniors, or they can read from textbooks and become excellent physicians, they are taking their patients into disaster. So the first and foremost thing for a junior physician is to holistically look at this patient and do what is best for him. And what he cannot do, he must be very open to tell them that this is all I can do. I have to take the services of a few specialities. Medicine is multidisciplinary. I may have to follow it up with a lot of seniors. And by coming to a rational decision-making body, can you come out of trouble? If you try to do it on your own, with the medico-legal problems increasing in our country, it's not very long before they'll go to court.
What is the prevalence of carbapenems producing bacteria in your practice, and what is the best treatment option?
There's not a single antibiotic, but there's no what I mean to say is there is something that can make it innocuous, or it can make it not enough to be the end all. Carbapenems has been there for the last 2 decades. And what we are trying to find out is only 2 antibiotics have been discovered after carbapenems started creating havoc. And these 2 antibiotics, I'm sure, are reaching the end of the road. I think one was ceftazidime avibactam, and the other was, skips my mind. But if you have to, you cannot use monotherapy. Monotherapy can never be a battle against infections. So what is happening now in critical care practice? Although you go for culture reports, you will find that more than 3 to 4 organisms are invading you and not a single organism. And each of these organisms by culture have a different antibiotic which they are sensitive to. So to say that carbapenems will hit all antibiotics across the spectrum may be totally wrong.
So we thank you, Dr. Matthew, for your words of wisdom, advice from your total experience, and your valuable time at the Natco Pharma Specialty Clinic on 2024 studio. We wish you all the best.
I should conclude by saying that without industry, we are nowhere. And what you people do for us, we can never return back the good you've done for us, because without medicines, there is no doctor. And I feel that if doctors feel that they are superior human beings and can do everything, they must really say hats off to the pharmaceutical industry for having sustained them through all these trials and tribulations of the many years that have gone by.